Hello everyone, a very good afternoon to all of you. So today let's talk about multi-drug resistant tuberculosis. Okay, so we all know that tuberculosis is caused by Mycobacterium tuberculosis. Okay, so basically it is a chronic infectious disease predominantly affecting the lungs. Of course, it can affect any organs. Okay, so when I am going to call this as multi-drug resistant tuberculosis is these strains, if it is resistant to one of the few very important potent drugs used for the treatment of tuberculosis. Say for example, if a particular tuberculosis strain or a Mycobacterium tuberculosis strain is resistant to isoniazid and rifampicin, which are the first line drugs used in tuberculosis treatment, I am going to call that strain of tuberculosis as multi-drug resistant tuberculosis. Okay, so multi-drug resistant tuberculosis, the strain of the Mycobacterium tuberculosis should be resistant to at least isoniazid and rifampicin. Okay, so these are the two very important potent drugs which we give, or first line drugs which we prescribe for tuberculosis patient. So any tuberculosis strain which are resistant to these drugs becomes multi-drug resistant tuberculosis. So when a patient is acquiring these kind of multi-drug resistant tuberculosis strains, the treatment is going to be complex, it is going to be long, it is going to be expensive. So there's going to be more mortality and morbidity for these patients. Okay, now what do you mean by multi-drug resistant tuberculosis? Is, as I told you, the strains of the Mycobacterium tuberculosis will not, or will be unaffected by the first line of drugs, isoniazid and rifampicin. So what happens, I'll give a combination of drugs, I'll give more drugs to counteract this. That is what I am saying, it will be increased mortality and morbidity for these patients. Okay, so if you look at epidemiology, so India is one of the major facing the major concerns of these patients with multi-drug tuberculosis resistance, and the risk patients will be in patients who are previously affected by tuberculosis. Okay, so previously affected TB patients. Okay, patients who are immunocompromised. HIV patients, patients who are in close contact with these multi-drug resistant strains of tuberculosis patients. So if a patient, say for example, if I'm having multi-drug resistant strains of tuberculosis, if another person comes in contact with me, so there are chances of spreading to that patient. So when they are in close contact with this, already patients who are affected with these kind of strains, and patients who are, they are not following up or they are not compliant. Okay, poor follow-up. Okay, so the patients who are diagnosed as TB and they refuse to take the drugs, so these group of patients are high risk patients of developing multi-drug resistant tuberculosis. Okay, so what is the cause of the development of this? Is basically there will be some genetic mutations in these Mycobacterium tuberculosis which will make these bacteria to become more resistant to the first line drugs like rifampicin and isoniazid. Okay, so if you look at certain genetic mutations, okay, so certain genetic mutation, potential MCQ, very important. Okay, so RPOB gene and CAG gene, so there will be genetic mutations of these genes which are present in Mycobacterium tuberculosis. So the mutation of RPOB gene makes these bacteria resistant to rifampicin, and the mutation of CAG gene makes these Mycobacterium strains resistant to isoniazid. Okay, so this is what the genetic mutation takes place. Okay, so because of these genetic mutations, the Mycobacterium tuberculosis bacteria, it changes itself, or there is some kind of changes which makes them more resistant to the first line drugs like rifampicin and isoniazid. What will be the etiology? Etiology of these primary drug, the drug resistant, multi-drug resistant tuberculosis will be, one is acquired resistance. What do you mean by acquired resistance? Of course, it's straightforward. So when I come in contact directly with a patient who are already having multi-drug resistant strains, then I'm going to get affected by the same multi-drug resistant strains of tuberculosis. That becomes acquired resistance. So direct inheritance. Okay. And next one will be secondary resistance. This is very important. So secondary resistance is, say for example, if I'm having tuberculosis, not a multi-drug resistant tuberculosis, I'm just having a tuberculosis. If I'm not taking the drugs properly, improper drug intake, or there is poor supply of the TB drugs to me, poor supply, or improper regimen, poor absorption, or if everything is available but I am resisting or I am not cooperating to take the treatment, poor compliance. So these all will form the secondary resistance. So etiology will be acquired or secondary. Acquired will be direct inheritance of the persons or contact with the person who are having multi-drug resistant strains. Or secondary resistance can be improper drug intake, poor supply, improper regimen, poor absorption, and poor compliance. Okay, so genetic factors, we talked about genetic factors, that is the RPO, B gene and the CAG gene, and we talked about the how it is getting inherited, primary and secondary resistance. Okay, so next we move on to how to diagnose these patients. Okay, so diagnosis can be done by microscopy. Okay, of course microscopy can detect the the acid fast bacillus stains, but it cannot detect the drug resistance. Okay, acid fast bacillus stains can be detected. And culture, Lowenstein Jensen medium. Okay, so it is going to detect acid fast bacilli as well as susceptibility of the drugs. Okay, Lowenstein Jensen medium. Molecular test can be gene expert. Okay, RT-PCR. So it detects microbial tuberculosis and drug resistance. You can get the results in 2 hours. Okay, and drug susceptibility testing. So these are all the 4 tests which I can do. And you know um, the microscopy, of course we all know that I'm going to use Zale-Nielsen staining. Okay, so in microscopy I will not detect the drug resistance. Okay, Zale-Nielsen staining is used, and in culture Lowenstein Jensen medium I can detect both, and molecular test gene expert RT-PCR running, and drug susceptibility testing. So these are all the few diagnoses of how you can detect the patients with multi-drug resistant stains. And moving on to the treatment, so you have to memorize these drugs, at least a few very important drugs. Group A, which is most effective, and Group B and Group C. Okay, you should also learn about the side effects of the drugs. Say for example, linezolid will cause bone marrow suppression. So similarly, you will have side effects of all these drugs. You should be aware of it, because every single word can be a potential MCQ pertaining to this topic. Okay, now how to prevent it? How to prevent? Very simple. Early detection. Okay, early detection. 2 will be isolation and proper care of the patients. Like I'm just isolating the patients who are affected by these stains, and I'm giving proper ventilation, proper oxygen support for these patients. Proper isolation. And very important, we are observing the patient, whether the patient is taking the correct or right therapy at the right time. Okay, so directly observed therapy, which is DOTS. Okay, so I am directly observing the therapy, whether the patient is taking and following the regimen. So this is how I prevent the multi-drug resistance. So this is very important topic. Okay, multi-drug resistant tuberculosis. So I hope this video makes sense. So thank you so much for watching the video. Have a nice day.